Hi everyone, I'm John Lesher, a physiatrist and non-surgical spine and sports medicine physician with Piedmont Healthcare. Today we're going to talk about common injection procedures that I do for patients with chronic low back pain. Specifically, we're going to be talking about medial branch block injections as well as lumbar radiofrequency ablation, also called RFA. The procedures that we're going to talk about today are for patients with chronic low back pain. These procedures are not typically done for patients with sciatica or nerve pain radiating down the leg. Today I'm going to answer in layman's terms the most common questions I'm asked repeatedly about what these injections involve. Today we'll be focusing on the lumbar spine, and I'll be using models to explain exactly what happens. Please understand that I also perform these procedures on the cervical spine or neck, the thoracic spine, which is the middle back, as well as the knee joint. The medial branches are sensory nerves that send signals from the joints to our brain. Specifically, they send information like pain, pleasure, hot or cold to our brain. When our facet joints are irritated, they will stimulate these nerves, and then the nerves will send messages or impulses to our brain indicating back pain or discomfort. On this model, you can see exactly where the facet joints are. They are what we call paired joints, meaning there's one on the left and the right, and they extend from the top of our neck all the way to our lower back or sacrum level. In a young person, these joints have nice, smooth surfaces. As we mature, and as I like to say, collect birthdays, our facet joints will change. In this model, they show more arthritic changes in the facet joints. So on the side here where my index finger is, you will see that the surfaces are somewhat irregular and slightly red, indicating inflammation. Where my finger is on this side, the joint is clearly enlarged, red and edematous. That is suggestive of underlying arthritis and joint irritation. I like this model a lot because it helps show the nerve supply to the joint. What you see are two different kind of nerves. The first nerve is the larger nerve or longer nerve at this level and this level. These are the motor nerves that allow us to move our muscles and joints. These are not the nerves that we are targeting with medial branch block injections or the radiofrequency ablation. Instead, we are targeting the sensory nerves, which you can see more closely overlying the joint. These are finger-like projections, and each joint has a nerve supply from two separate nerves. So these sensory nerves are the nerves that we are specifically targeting with the medial branch block injections and the radiofrequency ablation. When I see a patient with chronic low back pain, I will try to determine if their pain is coming from the facet joints. Commonly, patients with facet-related pain will have pain if they stand upright or move backwards. With the model, when I move the model backwards, there will be more stress along these joints. If that is painful to the patient, that is a sign or symptom that some of their pain could be coming from these joints. Also, I will have the patient twist to one side and then the other side, which also loads the facet joints. Patients with facet-mediated pain may feel better when they are flexed forward or leaning forward. That will naturally open up the spaces of the joints to some degree that can provide relief. Some patients may feel better sitting down with their back supported or even slightly flexed forward. If my examination is suggestive of facet-related pain, and it's endorsed by the patient, my next step typically will trial medial branch block injections. The medial branch block injections are done under X-ray guidance or fluoroscopic guidance in my office. I will typically inject a small amount of lidocaine and target the medial branches. Specifically, I will guide a needle, you see here, down to this bony area close to the facet joint. And I will typically inject a small aliquot or amount of 2% lidocaine. Typically about 2% of, typically I will inject a half cc of lidocaine to cover both of these nerves at this level. Typically, if a patient is having right-sided lower back pain, I will target 3 locations. And if they're having bilateral or both-sided back pain, I will target 3 locations on the right side and 3 locations on the left side. The lidocaine injections begin taking effect immediately. Lidocaine starts acting within the first few minutes of it being injected and typically lasts anywhere between 1 to 3 hours. However, the duration of the lidocaine is variable and depends on a patient's age, anatomy, and overall activity level. After the lidocaine injections are performed, I encourage patients to go home and take their back for a test drive. I want them to be active and do activities that are usually painful for them to see if the effects of the lidocaine diminish or ideally eliminate their pain. What we don't want is for patients to go home and rest on the couch or take a nap. If you do that, the response to the injection isn't going to tell us much at all. Please understand that there is no cortisone or steroid injected in these injections. So these are very short-acting tests of how you feel while the lidocaine is working. We don't expect the lidocaine to last for 24, 48, or more than 72 hours. We just want it to last really for a few hours and assess your response. What is considered a successful medial branch block injection? Ideally, we want to perform the lidocaine injection and have 100% relief of the patient's pain. More realistically, however, if we get at least 50% improvement and the patient feels that their overall activity and function was significantly improved, that is considered a positive response. If you have that type of response, we will typically repeat the injection a second time. That is to rule out what we call a false positive response. If a patient responds very well to one injection and has a marginal or mediocre response to the second injection, we consider that an overall negative response. And then I would see the patient back to further evaluate them to try to determine other causes of their low back pain. If a patient has 2 very good or positive responses, that's highly likely or highly suggestive that some, if not all of their back pain is coming from the facet joints. And then we would move forward to performing radiofrequency ablation, or what we call RFA. Once we have verified that the pain is coming from the facet joints, we will move forward with the RFA procedure. The RFA procedure is also done in my office. It is not surgery, and no scalpel incisions are involved. It commonly takes 30 to 60 minutes and is covered by most insurers, as long as appropriate criteria have been met. And the criteria typically involves positive responses to 2 separate trials of the medial branch block injections. Radiofrequency ablation technology has been around for almost 100 years and is commonly used in other parts of the body, including the heart, the liver, the kidney, the bones, and the uterus. To maximize patient comfort with the RFA procedure, we can provide a mild sedative before the procedure like Valium, or offer nitrous oxide or laughing gas. Radiofrequency ablation is performed by using high frequency voltage to create heat that ultimately creates a thermal lesion or destruction of the sensory nerves. When the medial branches are destroyed by the thermal heat, the pain signal that transfers from the joint to the brain is disrupted. By decreasing that pain signal, your brain then no longer feels the pain coming from the arthritic joint. When I perform RFA in the office, I will guide a needle or cannula under X-ray guidance to the level of the medial branches seen here. This needle has a special tip that will heat up. The X-ray guidance allows me to place the needle very precisely near these white finger-like nerve structures. Once I'm in the appropriate position, we will turn the radiofrequency generator on, and that will create a heat temperature to approximately 80 to 90 degrees Celsius for approximately 60 to 90 seconds. The heat creates a thermal lesion, ultimately destroying these medial branches. After the first cycle, I will adjust this cannula slightly to then target a slightly different area of the medial branch. Again, we will run that cycle for approximately 60 to 90 seconds, and the heat will range anywhere between 80 to 90 degrees Celsius. This nerve destruction is not permanent, and the nerve fibers will usually start to grow back slowly, approximately 1 millimeter per day. However, this can be highly variable based on a patient's age, their overall health, and their anatomy. The goal of the radiofrequency ablation is to ideally maximize the lesion created by this cannula, targeting these sensory nerves, while at the same time minimizing any kind of damage to the surrounding tissues. During the ablation, it is very common for a patient to feel some pain and/or fullness sensation, or even a burning type sensation in their lower back or buttock area. What we don't want is the patient to feel any type of radiating pain from their buttock, down their leg, or into their toes. The procedure is relatively safe because I am talking to patients throughout the entire procedure. If the patient does experience any leg pain or radiating pain from the buttock down into their foot, we will stop the ablation immediately and then redirect the cannula, ensuring that it's in a position that does not create any radiating leg pain. Once the ablation is completed, I will typically recommend relative rest for the first 24 hours. After the first 24 hours, then I will typically recommend gradually resuming light and normal activities. Please understand that the radiofrequency ablation is creating a thermal lesion and destruction of tissue. This could cause pain to initially increase for the first few days, if not during the first week. I do provide supplemental pain medications to patients during this time. Please understand that the effects of the radiofrequency ablation, specifically pain relief, does not happen immediately. This is more gradual and usually starts to take effect over 2 to 4 weeks. I always see patients back at 6 weeks following the procedure to gauge its overall effectiveness. At that time, we will definitely know if the procedure has helped you. A successful RFA procedure can provide pain relief lasting anywhere between 6 to 18 months or longer. The procedure can be repeated in the future if the pain returns. Remember that the RFA procedure is not a permanent solution, and these sensory nerves do grow back gradually over time. The procedure can be repeated again in the future, and insurance will usually pay for it at least 1 to 2 times per year. I hope this video has been helpful in explaining the medial branch block injections and RFA procedure. If you have any additional questions or concerns, please feel free to contact our office at the phone number listed on the screen. Thank you again.